It's my pleasure to introduce to you our second speaker. We'll talk about field surgery in most austere and challenging conditions. Dr. Mansoor Khan is a fellow of Royal College of Surgeons, fellow of European Board of Surgery, and fellow of American College of Surgeons. His experience is a pagoscopic trauma and general surgeon, honorary professor of surgery at Brighton and Sussex University Hospital. He's a retired surgeon, commander of the Royal Navy, Trauma and Critical Care Fellowship at R. Adams Crowley Shock Trauma Center, former consultant advisor in general surgery to Medical Director General of the Royal Navy. He's a former senior lecturer in military surgery, Royal Center for Defense Medicine. He's a visiting professor of physics at Imperial College of London and co-author of Trauma, Code Red, and Fundamentals of Frontline Surgery. Let's now welcome Dr. Mansoor Khan.
Now, thank you very much for the opportunity to present at this conference, and fascinating talk by Dr. Redmond to start off with. And I'll just continue on a similar frame and talk you through my thought processes of what basically austere and challenging environments can cause the surgeon. So as my colleagues have kindly already introduced me, I'm a former surgeon commander in the Royal Navy and retired a couple of years ago, but still I'm actively involved in training military and humanitarian surgeons around the world. So first of all, before we start anything, I do have to give you a disclaimer. These views are mine, only mine, don't represent anybody of any importance. So take what you will, discard what you want. Okay, but please just follow me through this thought process journey of mine. Now, one of the things I'm going to concentrate here on is trauma surgery in itself, especially in the deployed environment. And the fundamental reason for why I joined up and decided to do trauma surgery was to prevent this. Every single person who goes into a conflict zone, in a humanitarian zone, any zone whatsoever, does at the government's bequest or on part of their organization's role to help others. So they should be afforded the best possible care to bring them back. And it's not only the people you deploy with, but any person you have to treat in that environment deserves to have the best care that you possibly can so they can go back alive to their family members. So the fundamental reason why we do what we do is to help patients and decrease or even prevent mortality. So what makes surgery challenging? Well, I'll be honest with you. People turn around to me and say, oh, you know what, it's a different form of surgery. The incision remains the same. The patient physiology remains the same, okay? The patient doesn't change. The technique doesn't change. What changes are the resources and the mindset. You will not have the same amount of equipment, and your mindset has to actually think about other factors which will come into play, which I will touch on as we go through this talk. So surgery in itself, what we have to do is go back to basics. In times of conflict, in times of austerity, what you need to do is fall back on your basic level of training. This is where your skill set, whether you be a clinician, a surgeon, you have to go back to the fundamental basics. You may not have a CT, in fact, you will not have a CT scanner. You will, if you're lucky, have an X-ray. If you're really, really lucky, have an ultrasound machine, okay? So you need to go back to your clinical diagnosis, and also, this is where I think it's paramount. This is where you want experienced healthcare professionals deploying, because they will have seen a huge spectrum of patients and they can fall back to their clinical skills, their clinical experience, which will help diagnose. So you cannot overtrain enough before you do humanitarian and conflict surgery. It is not sexy. It is really hard work. There are huge periods of inactivity followed by sporadic overactivity, but we will talk more about this as we get into it. Unfortunately, over recent years, and I know my international colleagues will agree with me, in all clinical fields, this is not just in surgery, there has been a massive drive on subspecialization. I sometimes facetiously say we have GI surgeons now, one set who will deal with the left side of the colon, one who will deal with the right side of the colon. I am yet to find an appendicular specific surgeon, but I tell you what, it's on their way. There is also less open work. People are concentrating more on minimally invasive surgery, whether that be laparoscopic or endovascular. And in fact, I have seen a significant rise in fellowships now concentrating on open work. When I was training, you used to do open work and do fellowships in minimally invasive surgery. Now, minimally invasive surgery seems to be foremost, and what we're doing is we're concentrating more on the open work. So the entire skill set has gone. And what this does, it makes us become less and less general surgeons, which is what is really, really required. Now, military surgery. What do we talk about here? Well, a military surgeon encompasses a whole spectrum of surgical specialties, but a military surgeon is an individual who deploys to a specific zone on bequest of the government to fulfill a certain task. And it is not just a case of trauma surgery, okay? It is not just a case of emergency general surgery. It could also be maxillofacial, plastic, obstetrics and gynecology. We will come on to this. It is a whole spectrum of techniques and skills which an individual needs to have. But please take a note, not all military surgeons are trauma surgeons, not all military surgeons are emergency general surgeons or acute care surgeons. But please follow my thought processes if you are still with me. So military surgery. Then you have acute care surgeon. And I follow the American verbiage on this because an acute care surgeon is a surgeon who specializes in general surgical acute pathologies as well as their perioperative management. That includes optimizing them and post-operative care, looking after them in ICU. Yet again, as you can see, a very, very specific set of skills. And in order for you to be an acute care surgeon, you need to be a darn good general surgeon because you need to be able to deal with all emergency general surgical specialties. And then finally, a trauma surgeon. I love this quote. A trauma surgeon is a surgeon who operates to patient physiology, not to anatomy. You'll go into the chest, you'll do vascular, you will do abdominal control, anything that is required, and you will do it. Now, if you take all of these caveats by itself, you could spend a lifetime in each section and not be specialized. So my personal view is to be a deployed surgeon, and when I say a deployed surgeon, I mean military and humanitarian, because the skill set required is so diverse. You need to actually, let's go back here. You need to sit in that middle portion right there. You need to have that skill set. Now, this is what I'm talking about is the gold standard, I believe. We can always aspire to be here. I'll be honest with you, I could train for the rest of my life and I will not be there. But you know what? This is what medicine allows you to do, is continually improve yourself. But when you're improving yourself, you're improving yourself for the betterment of the care for the individuals you provide, okay? That is the fundamental thing. So what do we need in the future? I have broken this down into 3 subsets of surgeons which are required in deployed operations. And when I talk about deployed operations, I hope Dr. Redmond doesn't mind, but I'm talking about humanitarian in this as well. We're talking about a kinetic surgeon, a humanitarian surgeon, and a contingency surgeon. If we break it down into 3 categories, a kinetic surgeon is a surgeon who deploys to an active hot zone where you'll be dealing with a high volume of casualties, whether it be internal conflict, war, etc. That surgeon has to have a skill set of dealing with penetrating trauma, blast, ballistic injuries, all of that. You then have a humanitarian surgeon. And as you're well aware, once a humanitarian incident occurs, it will probably take 24, 48 hours to get a team across there. Anybody who has got serious injuries or who has got catastrophic injuries requiring urgent life-saving care will not survive until the team arrives. What you do find, and I believe my colleagues may agree with me, is once you have a humanitarian incident such as an earthquake, a flood, tsunami, any massive internal displacement, and I've spoken to a lot of my humanitarian colleagues and experienced this myself. Do you know what the biggest burden is? I think Dr. Redmond did touch on this, is the obstetric overload. Any lady who is peripartum, who is just about to give birth, will just suddenly start to go into labor. And I've spoken with my colleague, Professor Knott, on numerous occasions. He spends most of his time on acute deployments, actually doing C-sections and just delivering children, because that's what happens. People go in, undergo labor. So you can see kinetic surgery, blast ballistics, humanitarian surgery. You know what? You deal with anything that comes in through the door. But the most challenging of all of these is the contingency surgeon. It's when you deploy and you sit there, and you are there as an insurance or some form of waiting and reacting to when events occur. And I have a lot of my colleagues who I get quite irate with, who are like, oh, you know what, I don't want to be contingency. I want to be out there doing operating. Well, I'm a really lazy surgeon, because for me to be busy means somebody is having the worst day of their life. I would rather go sit there on my backside for months at an end without anything to do, because that means nobody is getting seriously injured. The caveat to that is, how long can you go there and sit on your backside with nothing to do? And roughly, I will say it's about 3 to 4 months before you start to get skill fade. So if you are doing contingency ops, they should only be done in short, sharp bursts so you can come back and maintain your skills. I'm also a firm believer in individuals should not only just deploy and do humanitarian operations. What they should do is go back to their native countries and get themselves involved in the healthcare infrastructure, because if you're involved in just doing one aspect of it, you are missing out on developments. You are missing out on translational medicine or surgery, which you can take from civilian practice, shall I say, into war zones, into these kind of areas. I hope you're all following me so far. So what we do require, and I'll keep going on about it, is the general surgeon. The general surgeon is currently dead, can I say? We need to resurrect them, okay? We need to resurrect this specialty which focuses on, you know, as opposed to patient turnover, meeting quotas in the healthcare service. You just need to be able to provide this care. And I tell you what, it's a very, very rare niche specialty. You can kill me later. This is the only paper I'm quoting by myself, okay? And the only reason I'm quoting this is when I was in the military, I developed a key set of skills the general surgeon must be able to do. And remember, this is not orthopedics. We normally deploy with a fellow orthopedic surgeon, although we can provide a one-man team, a surgical team, which can do emergency orthopedics, provide external fixators, gas. But normally we deploy as a two-person team, general surgeon and orthopedics. And I've been lucky enough to work with some of my great friends on this. But what a general surgeon deployed will provide: neurosurgery, burr holes, deep unfractured craniotomy, ophthalmology, basically maintaining globe integrity, ENT, putting in a tracheostomy, thoracotomies, laparotomies. You see all those things. All of those are skill sets which I believe a deployed general surgeon should be able to meet at a basic minimum. And the only way to meet these skill sets is by actually having exposure to these in elective practice. When I was in the military, I used to go to obstetric lists. I used to actually go up to neurosurgical lists, know how to do these procedures, because you never want this first procedure to be when you deploy. You need to have that skill set. And remember, deployment is not an experimentation zone. You need to be fully fledged with these skills, and these are life-saving skills for you to do. So what are the challenges? As I've mentioned, okay, subspecialization. We need to revert back to general surgery, because currently we are focusing on a specific region, not even a cavity. Now, I'm an esophagogastric surgeon, so I concentrate on the esophagus and the stomach. But when I do my general surgical on call, I actually start off all the way back at the top, at the start of the esophagus, and I'll finish at the dentate line. So the tube from your mouth to your anus is mine, okay? I will operate on all that, but you have a few individuals who will not be able to do that. And the way you get around that is by gaining competencies. Manning. How do you get these individuals, okay? How do you recruit them? Well, then yet again, that is targeted acquisition, making sure you only acquire the people with this skill set for your organization, whether they be humanitarian, whether they be military. Now, I want to talk about prolonged field care. I briefly want to touch on this. The military is very, very keen on prolonged field care. And the definition of this is holding on to a sicker patient longer than you want to, with fewer resources than you need in a place you don't want to be. And I've got to say, when you have prolonged field care is not a medical decision. It is a decision made by a government and an organization, okay, where they will accept a certain degree of casualty and mortality to gain their mission. Okay, remember, prolonged field care, if you do take anything away from this, is not a medical decision. It is a command. It is a senior organizational decision. And my personal view is, if you can't bring the patient back, you have to push the capability forward. I'm not one for mitigating medical standards. I have my skill set, but with your skill set, that only takes you so far. You need resources, and resources are both in terms of manpower and logistics, okay, to provide that care. So what are the capabilities of a forward surgical team? Well, it purely depends on what your mission is, okay? What is the mission? Is it a kinetic? Is it a humanitarian? Or is it a contingency operation? Are you dealing with a small team of 4 personnel? Are you dealing with a large contingent of a few thousand people? You need to actually do the medical logistics, and you need to have a plan on what you are going to provide for. Only by implementing this plan will you be able to deliver. My last deployment, I was in South Sudan. I was part of a forward surgical team, which was me, an orthopedic surgeon, my theatre personnel, anaesthetist. We also had a plastic surgeon deployed, but we only had a handful of units of PET red cells, a handful of units of plasma. Now, if I have 2 casualties come in, one of the casualties I know has got a major injury, will require 30 units of blood cells, okay? And another casualty, which will only require a handful, who do you treat? Everyone talks about, oh, we have a walking blood bank. Yeah, great, okay, that's really good for the emergency situation. But when you're deployed out there for 4 or 6 months, you can only take so much blood off individuals. And I believe some of my colleagues here have used whole blood. I'm a huge fan of fresh whole blood. I've never seen bleeding stop like it does when you use fresh whole blood from one person straight into another. It's like human araldite. Everything just stops. But the logistics associated with that are absolutely massive. As I've mentioned, what are the resources? And the resources just are not the blood products, okay? How many theatre sets do you have? What's their sterilization capability? How many patients can you hold, okay? How many patients can you operate on the same time? And I'll come on to a bit more of this when I go into my next slide. Difficult decisions, as I mentioned before, who do you operate upon? Okay, you have your own soldier who is injured, who requires 50 units of blood products, maybe 30. You have a local national who requires a handful of units. Simple answer is you treat the patient based on their physiology and their survivability. Nationality on all of that stuff goes out the door. Okay, you treat the patient based on their clinical need and their survivability based on the resources. I told you I was going to be controversial, didn't I? The technology now we're going to talk about. Many of you out there have heard about Reboa. I've heard people say, you know what, I can put a Reboa catheter in somebody with major trauma, with subdiaphragmatic bleeding, and we can operate on somebody while waiting for this. Well, if you've got somebody with severe compromise, you've got about 15 or 20 minutes for that Reboa catheter in zone 1 before you have a patient who is alive above the diaphragm and totally dead below it. So can you tell me you can operate on somebody and get them off the operating table within 20 minutes to get that other patient on? So you need to be quite pragmatic. There are other technologies out there currently being trialed, I believe, at Harvard and in Texas, rescue foam, which shows a bit of promise. But you need to apply the technology based on your skill capability and the outlook of the patient, not because it's a good idea and you want to write a paper of how you deployed it in this environment. Biggest take-home message. You are only, and when I talk about you, I'm talking about the team. are only as strong as your weakest link, whether that be skill set, whether that be resources, whether that be government or organizational backing, okay? You are only as strong as your weakest link, and that is the message you want to take away. You can have great ideas, deploy with everything, okay? You can deploy with 100 units of red cells, but if your turnaround time is 3 days and you've got no storage capacity for them, your electricity is temperamental, you have no clean water for sterilization, well, you need to look at the whole package. There are so many challenges to operational forward surgical operating. I've operated in a tent, and I'll be honest with you, doing an appendix in a tent is so much more challenging than doing it back in an NHS or a governmental hospital setting in a state. Your lighting, your suction, okay, water, dust everywhere. People spend ages trying to clean stuff, but the moment you open a door, all that dust flies in, and I'll show you what I mean by that from my next picture. This was my last deployment in South Sudan. That red sand gets everywhere. It's like talcum powder. You cannot get it out, but you can only do the best you can. A no talk is a talk which I give without an absolutely shameless plug, okay? And I'll be honest with you, I do very much like Dr. Redmond did with this. I do not take away any proceeds from these books. So I will, Frontline Surgery, written by one of my colleagues, I'm very good friends, Matthew Martin, great book. I will not tell you to buy one specific book. I will tell you to get the book from a library, read the book, and take the message away from the book. Education, I believe, should be free, should be no expense, but these, obviously, Fundamentals of Frontline Surgery and Trauma Code Red are the best books ever written, okay? After Tolkien, Lord of the Rings, best things you can ever read. But on a serious note, please just go away, read, improve your clinical skills, improve your knowledge, because everything you do is going to be for the betterment of your patient, and there is no better feeling in the world than looking after somebody and them looking you in the eyes and genuinely thanking you, okay? Nothing beats that at all. And getting somebody back to their loved ones, I tell you, if you believe in prayers, if you believe in rewards, there is no better reward than having genuine sincerity and gratefulness from somebody who you've treated and you know you've made a difference to their lives. Thank you so much for listening.